All right, we're going to go ahead and get started. I have a couple of announcements, and then I'll give you a rundown for how this session is going to work. So first, we're restarting grant writing office hours on November 5th. They will be alternating Wednesdays on Zoom for 2 to 3 hours at a time. The time is TBD. It is based on the participants' availability. So if you're interested, check your email. You should see a message about grant writing office hours via Zoom and sign up if you're interested, and you'll get details. A quick reminder that there's no workshop this week on Friday. Be sure to join us the following week for the Pop Studies trainee presentations. And for those of you who are students in the Minnesota Demography and Aging seminar class, please sign in. Lindsay isn't here to take attendance, so sign in. The sheet is on the table with the beverages. All right, so the plan for today is we're going to hear 4 flash presentations. All of our center leadership is represented in this set of flash sessions. So this is a big deal. I'll be moderating the sessions. For presenters, I'll be right behind Steve and in front of Braden, and I'll have 1 minute and 3 minutes warning signs for you. The presentations are 7 minutes total, so I'll try to get your attention and let you know how much time you have left. We will not take any questions immediately after the sessions. We're going to go right from one presentation into the other. The Q&A will happen at the tables. So Janette's on the end over here, and then Andy and Julia here in the middle, Steve at this table, and Theresa at this table. Folks who are not presenting are welcome to get up and move around. If they have asked their question or they want to join a different table, you're not stuck at the table where you start. Please feel free to move. Okay, for those of you on Zoom, you will get to hear the presentations, but once we move into the Q&A, after the presentations are done, Zoom will end, and you can send the authors an email if you want to talk to them or find them in the office. All right, so our first presentation is Steve Ruggles, Professor of History, Director of IPUMS. The title of his talk is The Pig and the Python, Labor Force Flows in the United States, 1940 to 1900 to 20. You changed the title, 1910 to 2040. Thanks, Steve.
I did. Okay. This graph is a illustration from a 1971 New York Times article called the New Census Trend, the Bulging Generation. And it's an age distribution in the shape of a python. And the article explained that there's this bulge in the population that resembled what happens when a pig is eaten by a python. And the baby boom age group sticks out like the python's dinner. And all things being equal, the bulge moves gradually along the length of the snake until it's fully digested. So the pig and the python was at the center of one of the major demographic debates of the 20th century. Richard Easterlin argued that the baby boom happened because of the small cohorts born in the Depression had very high incomes compared with their parents. And so they married early, they had lots of babies, and they had these high incomes because they faced very low competition for education in the job market and whatnot, because there were very few of them. And he correctly predicted that when the baby boomers hit the job market, their incomes would plunge and their fertility would decline. And so the theory fits pretty well for the 1940 to 1980 period, but Easterlin gave his presidential address in 1978 on what was going to happen in 1984, and he predicted that, well, it's all going to turn around, incomes are going to go back up, and fertility is going to be another baby boom. And this is his method. It's called relative cohort size. It's the ratio of men age 15 to 29 to men age 30 to 64. So this is the lucky few. These are the guys who made the baby boom. There were very few of them. they did very, very well. Their incomes went up. Here's the baby boomers, not so good, lots of competition. This is where he made the presidential address. And this is when he predicted that everything's going to turn around because of the declining number of young men entering the labor force. Well, here's what really happened. This is median wages for full-time earners, age 25 to 29. And here's the lucky few. That was correct. It went up. Here's the baby boomers. That's also correct. They hit the job market and incomes plunged. But here's 1984. It kept going down after 1984, and in fact reached a low point in 2014. Median wages for young people. Okay, so what are the problems with this theory? Well, one thing, it ignores women. Easterlin thought that women didn't compete with men. They had different kinds of jobs because of occupational segmentation. Anyway, only men counted for family formation. Obviously, from today's perspective, that's absurd. He ignored immigration and the relaxation of immigration restrictions in 1965 had a huge impact on the labor force. And maybe most important, he ignores retirement. It was kind of like the same argument as with women. He thought that retiring people weren't really competing with entering people because they had lots of experience and stuff like that. And so, but I think that that's also absurd because if people retire, then other people can move up the ladder, and eventually it percolates down to the entry level workers. So my alternative approach is to measure labor force flows, and I do not have enough time to explain the methods. If you want to ask me, I have the slides on my laptop over there, and I can show you the slides on the methods, but I'm just going to show you the results. So this is the number of decennial entrants into the labor forces ages 16 to 29. So these are people who are 16 to 29 at the end of each decade, and this is the number of people who entered the labor force among U.S.-born persons in that period. And you can see the bump up in the middle. This is Easterlin's thing. It's partly due to cohort size, partly due to entry of women in the labor force. There's actually a second bump in the 2020s, which is now a second peak, and it went down in between. These are exits from the labor force among people aged 50 to 89, and you can see that that goes up monotonically, except for a little dip in the 1940s as going to the 1950s, where the women left the labor force after the war. I also looked at women aged 30 to 49. That's the age group in between the entrants and the exiters, and that's because married women were entering the labor force in large numbers. In this age group, there was a net departures from the labor force for the first half of the century, but then there was a big increase in the middle, then we have the immigrants. All of that was U.S. born. This is the whole immigrant population, all age groups. And you can see the peak is quite a bit later. It's in the 2000s rather than the 1970s and they were leaving as well in the early part of the century. That's because there was very restrictive immigration laws and they were just aging out. They were retiring or dying. Oh yeah, I forgot to mention, we do go to 2040. I've just projected the 2023 population, assuming constant, applying the 2022 life table, and I assume no change in the immigrant labor force. This is what happens if you add all of these together. And you can see we got the dual peaks. This is the immigrant peak. This is the everybody else peak. And the everybody else peak is about half cohort size and about half female labor force participation that drives it so high to 25 million people entering in the 1970s. This is the same thing for the grand total, but it's measured as a percentage of the working age population, just to try to control for the population growth. These previous graphs are all in absolute numbers of jobs, of labor force participants. So you can say, well, this is pretty much like the relative cohort Easterlin's graph. But this really shouldn't be taken as a sign of labor market competition because it implies people here and here were like about the same. But in fact, these people were way worse off than these people in terms of competition because all of these baby boomers were still there. And the baby boomers were still there and they kept going and they kept going. And so they 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 were blocking. Oh, it says stop. I'll be one second. I'll stop. Okay, so I'm proposing this measure, the index of employment competition, which is entrance over the last 50 years, which is long enough for most people's careers. And you can see that it fits with the income graph much better. And so the pig and the python stood in the way of another golden age. But if everything goes, if we don't have a dystopian collapse of society, we can expect that the unprecedented disappearance of people entering into the labor force, which is going to happen definitely by 2040, is going to lead to some pretty good consequences.
Thanks, Steve. All right, next up is Janette Dill. The title of Janette is the Associate Director of the Life Course Center and a professor in health policy and management. The title of her talk is Earnings Growth Among the Healthcare Workforce During the Pandemic and Recovery.
Actually, I changed mine
Okay. You can give your own titles.
Okay. All right. I'm going to talk about the unexpected compression in healthcare. All right. In the general US workforce, the lowest income earners saw the largest wage gains after the pandemic, leading to an unexpected compression of wage disparities. So that means people at the bottom sort of saw the largest wage gains following the pandemic. So the goal for the paper that I'm going to present today was to analyze whether a similar trend occurred in the healthcare sector based on inflation-adjusted median weekly earnings. And we use IPM CPS data from 2015 to 2024. And the reason for that long window is so that we could see patterns prior to the pandemic and following the pandemic. All right. So here are median earnings. Again, these are inflation adjusted, and I'll talk about that in a second. So these are median earnings across occupational groups in the healthcare sector. So we looked at a few different occupational groups. We have advanced practitioners, other healthcare professionals, which includes people like speech therapists, physical therapists, etc. We have RNs, community-based workers, technicians, and aides and assistants. You might notice we don't have physicians. The reason for that is because in the monthly data in the CPS, there's a fairly low threshold for top coding. And so a very high percentage of physicians have top coded wages, and we wanted to have a lot of confidence in our data. And we did make adjustments for top coding, but we still were concerned about the physicians because of the high rate of top coding. I will note that the physicians are only 6% of the healthcare workforce. So we are getting most of the healthcare workforce here. Okay, so you can see when you look at this that most wages or most weekly earnings for healthcare workers peaked around 2021, 2022, and then they started to decline. And this isn't because people had a pay cut, right? It's because of inflation eating into the wage gains that workers experienced following the pandemic. You can see that APs and other healthcare professionals had pretty significant declines following the pandemic. RNs and community-based workers and technicians held fairly steady, fairly stagnant. And then aides and assistants actually fared the best after the pandemic in terms of wage losses. So if we look at some percentages here, aides and assistants, this is for the whole period, 2015 to 2024. Aides and assistants experienced significantly larger wage growth over the study period as compared to all other occupational groups, and much of it was during the pandemic recovery. And then earnings for registered nurses or RNs and technicians saw relatively flat wage trends with modest gains of 3.8 and 1.1% respectively. All right, so then we looked across educational attainment. We have college degree or higher, associate's degree, some college, and then high school diploma or less. Again, no physicians included in the sample, but every other occupation. You can again see the wage losses for college degree and higher. And you can see that high school diploma or less sort of saw those early gains and were able to maintain them through the recovery period. So if we look at some percentages, we see that the largest relative earnings growth occurred among workers with a high school diploma, and this was significantly higher than those with some college and those with an associate degree and those with a college degree or higher. Those with an associate degree and those with some college had relatively stagnant growth of 2 and 8%. And then wages for college grads showed almost no growth at all over the study period. All right, so our results mostly align with broader labor market research documenting an unexpected compression of wage disparities after the pandemic. Additional analyses included in the paper show significantly larger wage growth among women as compared to men and a reduction in the gender wage gap during that time period. I will note in the healthcare sector, probably everyone knows this, but it is mostly made up of women. It's 75% women, so that's a big deal. And then Black and Hispanic workers also had significantly higher earnings growth than white workers following the pandemic. And then here's our citation for our forthcoming paper. Oh, and quickly, let me just acknowledge, I want to just acknowledge all of my co-authors on this paper.
All right, up next is, thanks, Janette. Up next is Theresa Osypuk. She's a professor in epidemiology and the director of the Minnesota Population Center. The title of her talk is The Influence of a Housing Voucher Experiment on Mortality, Fertility, and Family Formation After 30 Years. Thanks, Theresa.
Great. So today I'm going to talk about two grants that I just received, and I'm not going to show you results. I'm going to talk about the setup for the grants that we're going to execute over the next 4 or 5 years. So racial residential segregation in the US is high. It's a key feature of American inequality across the life course, and it operates partially through neighborhood context, including concentrated poverty neighborhoods. So these are graphs of dissimilarity. Over time, dissimilarity is a common measure of segregation, racial residential segregation. This is a trend graph from 1980 to 2020, and then projected out to 2040 from John Logan and Stoltz census data, and the solid line are Logan's data. Black-white segregation is in blue, Hispanic-white segregation, and Asian-white segregation. High segregation is at 60, moderate segregation is above 30, and low segregation is below 30. So you can see that black-white segregation has declined since 1980, and it has just gone below high segregation on average across the country over the last 7 or so years. Hispanic segregation is somewhat flatter, and Asian segregation is very flat over time. And these are moderate on average, and nowhere do we see that segregation is low in the country. The study I'm going to talk about is the Moving to Opportunity study. There are 5 regions those are focused on, and these are the dotted lines for Black-white segregation, Hispanic-white segregation, and Asian-white segregation is higher in all 5 of those cities. Baltimore, Boston, Chicago, LA, and New York. This is a visual representation of racial residential segregation in New York City. where one dot represents 25 people in the 2010 census. And this is the key for different racial ethnic groups. And the dissimilarity index for those groups in New York, racial residential segregation is much higher than other cities, and density is much higher, which is why it's so visually striking. You can see the segregation very strikingly in New York. So racial residential segregation is high. Segregation in neighborhood effects literatures are also methodologically weak when they're linked to outcomes and they're divorced from policy solutions. The Moving to Opportunity study is one exception. This study is a large experimental study of housing vouchers, comparing a randomized trial, a randomization of an offer of a housing voucher compared to the offer of remaining in public housing. Among low-income families, 4,600 low-income families, around 15,000 individuals, and baseline was in the 90s. This was authorized in the first Bush administration. So the innovation of my study is to extend the study beyond 2010, which is when the original study ended and the data collection ended, through 2024 to link to this study to other data in the Census Bureau's Federal Statistical Research Data Center, FSRDC. The new scientific aims are to test the main effects of the Moving to Opportunity housing voucher treatment on outcomes through year 2024 on health. We're looking at fertility, mortality, maternal morbidity, that's during pregnancy, and birth outcomes. We're looking at family formation, social mobility, education, income, housing, and employment, and then housing and neighborhood outcomes. This is the model looking over time, the random assignment to one of three treatments at baseline. This is the structure of the original study at interim and final. These are the different data sets we're using: National Death Index, Numidant, and CHCK, which allows us to ascertain birth through the Social Security data, natality birth files from state, the Census Master Address files, which is the master list of everyone's address in the United States, and the decennial census and the American Community Survey, and these link to what outcomes we are using in what years. So we're looking at socioeconomic status, income, education, employment, housing, family formation, address, and then when we link to address, we're going to link to neighborhood outcomes, including the quality of the neighborhood for residential mobility, low birth weight, maternal health, fertility, all-cause mortality, and cause-specific mortality. There are many benefits to working in the RDC. The RDC projects can be highly scientifically innovative since the barriers to entry are high and linkage at the individual level among the data is unique. UMN affiliates can use the RDC for free, unlike many other FSRDCs throughout the country. And you and the others can access the same data in the project space at FSRDCs across the country. So our team is spread throughout the country, including I also have collaborators here. And I want to thank NIH and the MNRDC, the R1 grant from NICHD I received, the RF1 co-I's Andy Fenelon, and Dave Van Riper, if Dave is also here, and R56 we received, and the center grants that subsidize the RDC. So thank you very much.
All right, our last presenter or pair of presenters are Julia Drew, who is a research scientist at IPPMS and director of US Microdata at IPPMS, and Andy Fenelon, who is a professor in epidemiology and associate director of the Minnesota Population Center. And they're going to tell you about IPPMS health surveys.
Great. Thanks for having me. So I'm going to give you a very quick overview of health surveys. which has been pretty much continuously funded since 2004 with the founding PI, Lynn Blewett. Now I'm MPI with Andy Fenelon. Welcome, Andy. We've got a new project segment that started in May of this year, and we're funded by an NICHD R01. So I'll really quickly go through what IPPMS Health Surveys is, what research has been done with IPPMS Health Surveys data, and then talk about what's next for us. And I also forgot, we have a number of people scattered throughout the room and on Zoom who contribute significantly to IPPMS NHIS and IPPMS MEPS, as well as other IPPMS projects. And so just want to acknowledge their hard work and contributions as well. So really quickly, I'm going to start with the assumption that most of you have at least some knowledge of IPPMS, and I invite you to check out our website to learn more. But IPPMS Health Surveys actually involves two different infrastructure websites. So there's the IPPMS NHIS, which offers an integrated version of the National Health Interview Survey. The NHIS has been collected since 1957 by the National Centers for Health Statistics. We have data in digital format back to 1963. It's the longest running annual survey of health in the United States, and it's representative of the civilian, non-institutionalized resident population of the United States. IPPMS MEPS offers an integrated version of the Medical Expenditure Panel Survey household component, and I think that one may be less familiar to people in this room. And it's an annually refreshed 2-year panel survey that's been collected annually since 1996 by the Agency for Healthcare Research and Quality. It's also representative of the civilian non-institutionalized resident population of the United States. And I only have 7 minutes, so again, visit our website if you would like to learn more, or visit with us at the table afterwards. So I'm just going to briefly share 2 examples of the fantastic population research that's been done with the data. This paper on Latino psychological distress by Amy Johnson and colleagues won the 2024 Health Surveys Research Award. And Johnson and her co-authors investigate whether the federal government's approach to deportation and more awareness of deportation by the US public led to growing psychological distress among Latino US residents across citizenship statuses. They find support that gradual increases in psychological distress among both Latino US citizens and non-citizens between 2011 and 2018 were due in part to the deportation threat-related mechanisms that they discuss in more depth in the paper. This paper by Jessica Ho won the 2023 Health Surveys Research Paper Award using integrated public use MEPS data from IPPMS on prescription medications and sociodemographic characteristics, combined with data from the Human Mortality Database and the National Center for Health Statistics. Ho applies a widely used demographic technique, Sullivan's method, if you're familiar with it, to estimate the number of years during their lifetimes that individuals can expect to be taking prescribed medicines. And she finds that for the average infant born in 2019, they can expect to spend roughly half of their lifetimes taking prescribed medications. And she's got some interesting findings on differences by sex, race and ethnicity, and then sort of the rates of polypharmacy and the types of drugs used. So really exciting research. There's other research that I love to talk about, so please check it out. And I will quickly discuss what's next. Got 3 minutes. So we will continue to lower the barriers to cutting edge longitudinal research, and we've got some exciting things that we're going to do with the data. So one is to add family pointers to MEPS. If you're not familiar with that, that's sort of something through our extract system that allows us to connect characteristics of other household members that are also have data collected on them, and easily bring that in so you can study the characteristics of parents for child outcomes or spousal characteristics for own outcomes. We're also going to harmonize some complex variables, including revisiting the NHIS occupation and industry codes. We've had a number of people who have used those data to look at deaths of despair, for example. We're going to try to bridge the ICD-9 to ICD-10 change by pulling out some sort of policy relevant variables that are going to support research across time. I'm working with some folks at SHADAC who are also on our advisory board to look at adding variables on health insurance instability, taking advantage of the fact that we have monthly health insurance statuses and coverage sources for 24 months, and adding those variables to our website so that people don't have to construct those themselves. And then also we're doing quite a bit of work to clean up the prescription medication data, which does have some inconsistencies. And then we'll release the cleaned up data and some additional variables that'll make that easier to use, especially for researchers who might not be pharmacologists. We're also going to enhance data access. So you should check out our website, but out of the last project segment, we added a new feature called the MEPS Variable Builder, which allows you to summarize variables on that are derived from data on these non-person records, and then attach them as brand new variables right through our extract system, so you don't have to manipulate the data yourself. And we're going to expand that to start working with the prescription medication data. And then we'll also add sort of additional functionality to, and I'm going to skip that. It's a lot. I actually skipped. You should see the number of slides that I took out. And then we're also going to continue to disseminate data to a broad, diverse spectrum of users. So that includes a number of conference exhibits and presentations, introductory workshops, and so on. If you have an idea for a workshop that you would like us to cover, please let us know. We're very responsive, and we develop new dissemination content all the time. So if you have an idea for something you'd like to see that would be particularly useful to you, please contact us. And then of particular interest, we're also going to do one 3-day in-person MEPS training workshop where we'll be flying people in to try to get people started. If you're a local user, you almost are guaranteed admission. So just keep an eye out for that, but we'll probably do that in 2028 or 2029. So, very long ranging. All right. And thanks to our funders and to all the people who work on this fabulous project. Thank you.
All right. Thank you again to all of our speakers. Speakers, there is a seminar series mug on the table. Please don't forget to take that with you before you leave. And then I invite everyone to join a table and ask questions of our presenters. Thank you.